This video is on the nephron. Let's just recap some anatomy that we've gone over so far. We say your kidneys look kind of like this. And if you look really closely, then you have a bunch of tubes that form this pyramid shape, right? And they drain into your calyces, and then eventually your renal pelvis, and then out your ureters, and you pee out whatever you're filtering, right? Well, in this video, we're going to look at these small little tubes in detail. And these small little tubes are your nephrons, the functional unit of your kidney. Functional unit of the kidney. So let's just blow it up and look at it in a little bit more detail. Your nephrons are these little tubes. And they're pretty complicated with many different parts, and we're going to talk about all these parts. But they kind of look like this. And you have a ton of these in your kidneys, and they all help you filter blood and plasma. At the top, at the cap of your nephron, you have this little sieve, kind of like a pasta strainer, yeah? And a blood vessel will go to this sieve and give it blood to filter. This we call the afferent arteriole. Afferent arteriole. And you know your arterioles will eventually become capillaries. Capillaries. And that's exactly what happens. It forms this bundle of capillaries called the glomerulus. Glomerulus. And fluid and plasma will go through the sieve called the Bowman's capsule. Bowman's capsule. And any fluid that's not going through the Bowman's capsule will leave via the efferent arteriole. And the efferent arteriole will eventually become something called the peritubular capillary. Peri means near, tubular means tube. So this is a capillary near our tube. And it is important because our tube, our nephron, will take all this fluid, filter it, excrete what needs to be excreted, but sometimes we have some valuables and we want to reabsorb that, right? We don't want to waste it. And we can reabsorb that by sending it back into our peritubular capillary, and that way it can go back to our venous system and get reabsorbed. That way we don't waste it. And then the things that we don't want to reabsorb, the thing we want to excrete, we'll just excrete it out. All right, so that's the function. It not only supplies our tube, but if we need to reabsorb things, we can send it back. It's like a return policy, if you will. That is your nephron. Now, there are many different parts of your nephron, and we're going to talk about all these parts now. This is the proximal side, the beginning side. This is the distal side. Yeah, the end. This proximal convoluted tubule is called the proximal convoluted tubule. This thin descending limb is called the thin descending limb. This thick ascending limb is called the thick ascending limb. This distal convoluted tubule is called the distal convoluted tubule, and this duct that collects all the fluid is called the collecting duct. Those are all the parts of your nephron. Hope it makes sense why we call it what we call it. Let's put it in. So we have our proximal convoluted tubule. We have our thin descending. We have our thick ascending. We have our distal convoluted tubule, and finally we have our collecting duct. Those are all the parts of your nephrons. We're going to talk about it in detail. We'll start with the proximal convoluted tubule. The proximal convoluted tubule is like the first thing the plasma hits. Yeah, the first thing all the fluid hits. And so you can imagine it's very, very important. This is where most of the things get reabsorbed. So I'll just write the powerhouse. How about that? The powerhouse of the nephron. So it can reabsorb things like phosphate, can reabsorb things like sodium. In fact, the majority of your sodium gets reabsorbed here. And just by osmosis, anytime you reabsorb sodium solutes, then water gets reabsorbed. So sodium, water, agua. How does it do that? Well, it has these special cells that will pump out hydrogen in exchange for sodium. Keeps things nice and balanced. Right? We call these NaH pumps. So pump out hydrogen, reabsorb sodium. Well, we don't want to just have this flying out willy-nilly, this hydrogen flying out willy-nilly. So hydrogen combines with bicarb, HCO3, and that will make carbonic acid, H2CO3. Now, H2CO3 gets worked on by an enzyme called carbonic anhydrase. Carbonic anhydrase. And it will become CO2 and water. And this CO2 and water can come back into our cell. And carbonic anhydrase in the cell will basically do the reverse. Turn it back to carbonic acid and eventually bicarb and H plus. The bicarb we reabsorb, so I'll say reabsorb bicarb. And the H plus, well, it's there for a second turn. So if you need to reabsorb more sodium, sodium will come in, H plus will get pumped out, cycle starts all over again. And if you're saying that's very small, I can't read that, I apologize. A better picture will be my notes. Okay, so make sure you understand that cycle well. And that's all facilitated by carbonic anhydrase. That's the main way we reabsorb our sodium. Now, if our body feels we need more sodium, we need more water, we can produce hormones to help us reabsorb more via the RAS pathway. There's going to be a whole video dedicated to it, but just to whet your appetite, one of the hormones of the RAS pathway is angiotensin II. Angiotensin II. And this revs up this pathway. So you reabsorb more sodium and you pump out more H plus just by nature. Can you think of what might go wrong if we rev this cycle up? Well, we're going to reabsorb our sodium. That's what we're trying to do. But we're also going to reabsorb bicarb. Yeah, just by the nature of things. And this can cause something called contraction alkalosis. Contraction alkalosis, just from all that bicarb. That's just some physio that you should understand. All right? Now, we're not only here to reabsorb sodium. Like I said, your PCT is your workhorse. It reabsorbs a ton of other things. Helps you reabsorb most of your amino acids. We don't want any of that to go away. That's a valuable commodity. So reabsorbs most of your amino acids, reabsorbs most of your glucose. Again, valuable commodity. Don't want to let it go to waste. Something you should know, you can only reabsorb so much glucose before you hit a threshold where your body can't reabsorb it anymore. Your transporters are all full. And so if you look at it graphically, then you'll be reabsorbing, you'll hit a threshold, won't be able to reabsorb anymore. So this is reabsorption. Sometimes they like to throw graphs at you, so don't get too confused. You're reabsorbing, you hit that threshold, you can no longer reabsorb glucose. Or they might make it as an excretion graph. So you're not going to excrete any glucose because it's a valuable commodity, but once you hit that threshold, then you can't absorb anymore. So then you'll start excreting it, right? So this would be excretion. Many different ways they throw it at you, but all the same, all right? As long as you know that you can only take so much glucose, you should be fine. So your PCT is your workhorse, amino acids, glucose, all this stuff. Not only that, but it can produce hormones, mainly your 1-alpha hydroxylase hormone. 1-alpha hydroxylase, what the heck does that do? Hopefully you remember, this works on vitamin D. So you ingest vitamin D, goes to your liver to be 25 hydroxylated, is not active yet, then goes to your kidney to be 1 hydroxylated. via 1-alpha hydroxylase, and this will activate vitamin D. All right, so your PCT does a ton of things. Let's just recap. Reabsorbs sodium and bicarb at the expense of H+. Reabsorbs amino acid, reabsorbs glucose to a certain amount, and then also has a hormonal function, 1-alpha hydroxylase. That is your PCT. Let's move on. Let's move on to your thin descending limb. Thin descending. Your thin descending limb reabsorbs water, but not salts. So just reabsorbs water. What do you think that'll do to the urine? If you just take up all the water from the urine, what do you think will happen? It'll concentrate that urine. So this concentrates the urine. That's it for your thin descending. How about your thick ascending? Well, your thick ascending is like the brother of the thin descending. It does the exact opposite. So whereas this reabsorbs water, your thick ascending limb can't reabsorb water. It's impermeable. That's just a fancy way of saying it can't do it. Whereas this can't reabsorb salts, your thick ascending limb loves salts. Your thick ascending limb reabsorbs almost the most amount of salt via sodium, potassium, chloride channel. That's a lot of salt use, isn't it? That's a lot of salts. That is a ton of salts. And it'll reabsorb that into your peritubular capillary. Okay? Something you should know, sometimes potassium doesn't obey the law. Sometimes it leaks back. Potassium leaks back. And because potassium is positively charged, you get a positively charged lumen. And this positively charged lumen will push other positively charged ions away from it. You know, opposites attract, but same charges repel each other. So it'll push positive charged ions away from it. It says, get away from here. These positive charged ions include things like calcium and magnesium. So you should know your thick ascending limb also loves to reabsorb calcium and magnesium. Okay? So just to recap, your thick ascending limb, impermeable to water, but it loves to absorb salt. Na, K, Cl, and calcium and magnesium. Let's move on up to your distal convoluted tubule. Your distal convoluted tubule, people love to ask this question. Where in your tubule is the urine most dilute? It'd be in your distal convoluted tubule. So in your distal convoluted tubule, the urine is the most dilute. Now it also has other functions. It can reabsorb, you guessed it, sodium, via NaCl channel. Something important about this channel, calcium can also jump in on this channel, but because there's so much sodium and because sodium is so much more important, then calcium kind of has to wait its turn, and most of the time it doesn't get reabsorbed. So I'll just write calcium can jump in, but oftentimes it doesn't get a chance, basically. Here's something important. If you block this channel, then calcium can jump in. If you block this, then calcium can jump in, and we're going to talk about pharmacology later, but something that blocks it is thiazide diuretics. And don't thiazide diuretics cause hypercalcemia? Now you know why. So that's your DCT. We're on the last part already, collecting duct. Your collecting duct collects everything. It also has a function. It has something called the ENaC channel. And the ENaC channel helps reabsorb sodium. How great is that? It's very similar to here. It will help reabsorb sodium, but at the expense of hydrogen. So reabsorb sodium at expense of hydrogen and also potassium. All right, so absorb sodium, but then it'll pump out hydrogen and potassium. It also has another function. There are something called alpha intercalated cells that help excrete more hydrogen. Maybe you figured this out by now. Kidneys are very important for acid-base homeostasis. Now, hormones can work on your collecting duct. Another hormone of the RAS pathway is something called aldosterone. And aldosterone, because it's due to our RAS pathway, we want to absorb more sodium, absorb more water. So what do you think aldosterone does? I mean, where do you think it'll work? It'll work on our ENaC, right? Try to absorb that sodium. Try to absorb more water. And so rev this up, reabsorb more sodium, reabsorb more sodium. Can you think of why that might be a problem? You reabsorb more sodium, that's good, but that's at the expense of hydrogen and potassium. You're losing hydrogen and potassium. So you can have hypokalemia, you can have alkalosis. Don't you get that contraction, alkalosis, that fancy term we learned? So, all right, hypokalemia, contraction, alkalosis. How about if you are missing aldosterone? How about if you have hypoaldosteronism? Well then, you won't be able to work this channel. What do you think will happen then? Well, if you can't reabsorb sodium, then you can't excrete hydrogen and potassium. So in hypoaldosteronism, you get salt waste and you can't reabsorb sodium. You just pee it all out. And because you can't reabsorb sodium, then you retain hydrogen and you retain potassium. Sometimes we call that hyperkalemic acidosis. If you can remember the function of the ENaC channel, then you should be able to get any questions right. Okay. One more thing. There's another hormone that works on it called ADH. ADH. And this is another part of the RAS pathway. We said the RAS pathway is you trying to reabsorb more sodium, reabsorb more water. Well, ADH really loves the water part, so it reabsorbs more water. How does it reabsorb more water? Well, it works on these receptors called V2 receptors, and that increases water channels. We sometimes call these aquaporin channels. That's a fancy way of saying just water channels. And we can reabsorb more water. ADH actually causes like DNA changes, causes you to actually make more of these water channels in your collecting duct. And we can reabsorb more water. All right? And that way we can get more water into our body. Everything's good. Now, what can go wrong? You can imagine if we reabsorb too much water without any solutes, then we can dilute our body. And if you dilute your body, you get a whole bunch of complications. You get hyponatremia, hypokalemia, all this stuff just because you dilute our body with too much water. And so something that you should know that a lot of people forget, ADH says, I'll reabsorb all this water, but I know I also need to reabsorb some solutes just to kind of balance things out. So talk to its good friend, the thick ascending limb, and say, hey, could you help us reabsorb a little bit more solutes to balance things out? And so it says, sure, I can do that. So rev up your thick ascending limb channel, your sodium, potassium, chloride channel. And I'll also say, I'll throw in some urea as a bonus. So throw that in, kind of balance the water uptake, okay? You gotta know that. I've seen many questions on that. It'll talk about someone with increased ADH, SIADH. And then they might say, what other solutes are reabsorbing? Most people are thinking, solutes? I thought ADH just reabsorbs water. What do you mean by solutes? And then they miss the question. Look for urea, look for sodium, potassium chloride channel in the thick ascending limb. All right, that is your nephron. That's a lot more messier than I thought it'd be, but that is your nephron in a nutshell. That's it. As long as you know these key facts, I think you'll basically nail renal physiology. So that does it for normal physio. But on the step, they like to complicate physio with things like graphs and equations. So let's just talk about one of the most common graphs that they like to ask about. This is called the TFP graph. TFP graph. What the heck is that? Well, before I can talk about that, I just want to go over something. We reabsorb things at different rates, especially compared to water. For example, electrolytes, we reabsorb at the same rate as water because every time we reabsorb electrolyte, water follows. Yeah? But there are some things we reabsorb a little bit more vigorously. Can you think about some of the things we talked about? How about glucose? How about amino acid? And then there are some things we don't reabsorb. Yeah, we don't want to reabsorb them. We want to just excrete them. So that would be, I guess, we reabsorb that less vigorously than water. So compared to water, how fast do we reabsorb things? And that is the TFP chart. TF stands for the concentration of things in the tubular fluid, basically the nephron. P stands for the concentration in your plasma, in your blood. If you reabsorb things at the same rate as water, like most electrolytes, then TFP equals 1. If you reabsorb things more vigorously than water, like the glucose, like the amino acids, because those are valuable commodities, then you reabsorb that back into your blood. So plasma would increase, wouldn't it? The concentration of all that amino acid and all that glucose would increase in your plasma. And there'd be no more left in your nephron, in your tubular fluid. So mathematically, you have a giant denominator, and so that would mean TFP would be less than 1 if reabsorb, what do I want to say, vigorously? I like the word vigorously. But let's flip the script. Let's say you don't want to reabsorb something, you want to excrete it. Then none of it will go back into your blood, none of it will go back in your plasma. All of it will just stay into your nephron, into your tubular fluid. And mathematically, you have a huge numerator. TFP is greater than 1. Hopefully that's not too bad. Let's look at it graphically. This axis is the length of your tubule, basically the length of your nephron, length of tubule. And this is going to be your TFP. And this would just be 1. We said 1 is when you reabsorb things at the same rate of water, and we said most electrolytes we do that because, like I said, you reabsorb sodium, you reabsorb potassium, then water follows just by osmosis. So at 1 you get things like sodium, like chloride, like potassium, even urea, all these things. And then we said there are some things you want to reabsorb a little bit quicker, a little bit more vigorously because they're valuable commodities, like glucose, like amino acids. And that would be less than 1. It kind of looks like this. So we reabsorb it really, really fast along the tubule. Glucose, amino acids, and even bicarb. Bicarb is really important. Those are things we just want to pick up a little bit more quicker. And then there are some things that don't get reabsorbed at all. And these would be greater than 1, so they'd be up here. Now, I don't want to jump the gun, but I'm gonna. I don't want to jump the gun, but I'm gonna. There are some things that our blood will send into our tubule. That just doesn't get reabsorbed. That all of it stays in their tubular fluid. All of it just stays in your tubular fluid. None of it gets reabsorbed. Things like creatinine and inulin, and in fact, that's why we like it. Yeah, we like the fact that none of it gets reabsorbed. So right, creatinine, inulin. And there's one more called PAH. PAH not only gets sent in through the afferent arteriole and the glomerulus and the capillaries, but also at the end, your peritubular capillary will also send some over. So it's just a little bit more concentrated in your tubular fluid. That does it for the graph, and that actually does it for this video. That does it for renal physio. Again, if you know this video well, then physio should be a breeze. It's a lot to take in, so you might have to watch it a couple more times, but if you know it well, I think it'll be a breeze. Thanks.